Hello, I am your host Dr. Arun Kumar and welcome to Medical Guruji. Today we are diving deep into the serious health issue meningitis. It's an inflammation of the protective membrane covering the brain and the spinal cord. While it's often scary, understanding it is the first step toward fighting it. We will be using the latest World Health Organization, that is WHO guidelines published in this year, that is 2025, to break down how meningitis is diagnosed, treated and managed. This is crucial information for everyone, from healthcare workers to families. Meningitis is not just a rare disease, it is a global public health threat. In 2019 alone, there were estimated 2.5 million cases and over 236,000 deaths worldwide. The burden is heaviest in the low and middle income countries and hits young children under 5 particularly hard. Beyond the tragic loss of life, about 1 in 5 survivors of bacterial meningitis face long-term complications like physical disabilities, neurological issues, hearing loss, things that drastically changes lives. This also places a huge financial strain on families, especially in resource limited settings. Recognizing this global challenge, the world united in a call to action. WHO, along with global partners, developed a plan defeating meningitis by 2030. In the 2030, another defeating infectious disease is also there, that is rabies, and by 2030 in India. This roadmap aims to eliminate meningitis epidemics, drastically reduce vaccine preventable cases and deaths, and improve the quality of life for survivors. While vaccine are key, a major focus is improving the diagnosis, treatment, and long-term care. That's where these new WHO guidelines come in. These guidelines are designed for doctors, especially those in first or second level facilities. Think local clinic or district hospitals, as well as policymakers and health planners. They cover acute community acquired meningitis, meaning the infectious caught outside the hospital, in the children over 1 month old, adolescents, and adults. Because the initial symptoms of diagnostic steps are similar, they address both bacterial and viral meningitis. We won't be covering meningitis in newborn, that is under 1 month, hospital acquired cases, or chronic forms like TB or cryptococcal meningitis in this presentation. So, how does meningitis typically present? The classic signs are a rapid onset of fever, a stiff neck, severe headache, sensitivity to light, that is photophobia, or altered mental status like confusion, extreme tiredness, that is lethargy, or even coma. Having all three, that is fever, stiff neck, and altered mental status, strongly suggest bacterial meningitis, but only about a half of patients show this classical triad. Other symptoms include feeling generally unwell, nausea, vomiting. Seizures and specific neurological problems like weakness on one side or trouble with cranial nerves can also occur, often indicating the brain itself is also inflamed, that is meningoencephalitis, which is more common in bacterial cases. In infants, the sign can be less obvious, maybe fever or low body temperature, a bulging soft spot on the head, that is frontanel, being very lethargic or irritable, feeding poorly, or having an unusual cry. Doctors might also check for specific signs like Kernig's or Brudzinski sign, which involve pain or involuntary leg movements when checking the neck or legs, but these are not always present. Sometimes a specific type of rash, small red or purple spots that don't disappear when pressed, that is petechial or puric type of rash, can appear, especially with meningococcal disease, signaling a very severe infection spreading in the brainstem, in the bloodstream. Now, what causes the meningitis? While virus can cause it, bacterial meningitis is generally more severe and is main focus here. The most common bacterial culprits may vary by age and immune status. First one is Streptococcus pneumoniae, that is also known as pneumococcus, a leading cause, especially in adults. Vaccines have reduced its impact, but it is still a threat, particularly if someone has a head injury, sinus or ear infection, or has a weakened immune system. It can also cause outbreaks. Next is Neisseria meningitis, that is also known as meningococcus, a major cause in children and young adults. Six types, that is A, B, C, W, X, and Y, cause most disease. It is famous for causing epidemics, especially in the African meningitis belt. Vaccination, especially against type A, has made a huge difference there, but other types still cause outbreaks. In wealthier countries, type B, C, W, and Y cause sporadic cases and smaller outbreaks. Third one is Haemophilus influenzae. Mostly it affects the young children, especially type B, that is HIV. Widespread HIV vaccination has drastically reduced cases, but other types still occur. Next is the Streptococcus agalacti, that is group B Streptococcus GBS, a common cause in newborn, which are not covering in detail, but it also affects the infants under 3 months, pregnant women, and elderly, and those with chronic conditions. And last common is Listeria monocytogenes, often affects the pregnant women, people over 60, newborns, and those with weakened immunity. It often linked to the contaminated food. Okay, that's all the stage, that is a base. Now let's move into How clinician diagnose meningitis according to the WHO guidelines. This is critical because quick, accurate diagnosis saves the life. When meningitis is suspected, the most important diagnostic test is lumbar puncture, also known as LP or spinal tap. This involves carefully inserting a needle into lower back to collect a small sample of cerebrospinal fluid or CSF, the fluid surrounding the brain and spine. The guidelines strongly state this should be done as soon as possible, ideally before starting antibiotics, unless there's a specific reason not to. Why before antibiotics? Because antibiotics can quickly start clearing the bacteria, making it harder to find them in the CSF later. Is it safe? Generally, yes, when done correctly. But there are risks like headache, infection, or bleeding. The most serious, tough, rare risk is brain herniation if the pressure inside the skull is very high. Therefore, and lumbar puncture should not be done if the patient has a bleeding disorder, a skin infection near the puncture site, or is very unstable hemodynamically or with breathing. Also, if there are signs suggesting very high pressure inside the head, like a very low consciousness level, that is Glasgow coma score below 10. If you want to learn the Glasgow coma score scale, then there's a separate video on that. You can watch the video from the I button. And the next is specific neurological deficits, that is focal signs, cranial nerve problems, swelling of the optic nerve, that is papillary edema, new seizures in adults, or a severely weakened immune system. The lumbar puncture might need to be deferred. We will come back to when imaging might be needed first. Once the CSF is collected, it provides a wealth of clues. Clinicians first look at its appearance and measure the opening pressure. Normal CSF is clear like water. In bacterial meningitis, it is often looks cloudy and turbid because of high number of white blood cells fighting the infection. Viral meningitis CSF is usually clear. High opening pressure can also suggest bacterial meningitis. Then the lab test begin. The guidelines strongly recommend several key initial tests, like first one is gram stain. This is rapid staining technique viewed under a microscope. It can often show bacteria and tell if they are gram positive, that is appear purple, and gram negative appear pink, and their shape, that is round cocci or rod shaped bacilli. This gives a quick vital clue about the likely culprit. For example, gram positive cocci in pairs, that is diplococci, suggest pneumococcus. Gram negative pairs suggest meningococcus. Gram negative small rods, that is coccobacilli, suggest Haemophilus influenzae, and gram positive rods may be listeria. Its accuracy is generally good, especially specificity. Finding bacteria means it's likely bacterial meningitis. Second is the cell count, that is white blood cells, WBC count. Normally, CSF has a very few WBC, less than 5 in adults. Bacterial meningitis usually cause a large increase, that is pleocytosis, mostly neutrophils, a type of WBC that fight the bacteria. Viral meningitis usually cause a less dramatic increase and mostly lymphocytes. This test has a moderate sensitivity and specificity. Age matters here. Normal counts can be higher in infants. Third is the protein. Normally, CSF protein is low. Inflammation from the meningitis damages the blood-brain barrier, letting protein leak into the CSF. So levels are usually high in bacterial meningitis. This test has a good sensitivity but moderate specificity. Another test is glucose. CSF glucose is normally about 60% of glucose in blood. Bacteria consume glucose, so in bacterial meningitis, CSF glucose is typically low and the CSF to blood glucose ratio is often below 0.4. Viral meningitis usually does not affect the glucose level much. This test has a good sensitivity and specificity, especially the ratio. It is crucial to remember that no single test is perfect. Doctors interpret these results together considering the patient's symptoms. Starting antibiotics before the lumbar puncture can make these results less clear. What about the CSF lactate? This is another chemical the lab might measure. High lactate levels can help distinguish bacterial from viral meningitis. The guideline gives this a conditional recommendation suggesting it be considered only if antibiotics have not been started yet, because antibiotic can affect the result. Its diagnostic value is limited otherwise. While those initial tests gives clues, the gold standard for confirming bacterial meningitis is only the CSF culture. This involves trying to grow the bacteria from the CSF sample on a special nutrient plates in the lab. If bacteria grow, they can be definitely identified and crucially tested to see which antibiotics kill them. This is called antimicrobial susceptibility testing, or AST. You can watch the video on AST in playlist basic course for medical on antibiotics for medical students. There is a separate video on antimicrobial susceptibility testing. This guides specific treatment. Culture result take time, usually a day or two, which is why initial test and empiric treatment are also important. Like the other test, the change of growing bacteria decrease if antibiotics were given before the lumbar puncture. What about the faster tests? Like molecular tests, PCR, these are becoming increasingly importance. PCR looks for specific DNA or RNA of bacteria or virus in the CSF. It is often much faster than culture, results in hours, and can detect pathogens even after antibiotics have started. Although the yield might still decrease, PCR can be highly sensitive and specific for both for common culprits like pneumococcus, meningococcus, Haemophilus influenzae, and also viruses like enterovirus or herpes simplex virus. Multiplex PCR panels can test for many pathogens at once. These guidelines strongly recommend using PCR-based test on CSF when available. However, results must always be interpreted alongside the clinical picture and the lab findings. PCR does not replace culture and AST, which are still needed to check antibiotic resistance. Beyond CSF, blood tests are also vital. First one is blood culture. Just like CSF culture, trying to grow bacteria from the blood is crucial. Bacteria causing meningitis often also circulate in the blood, that is bacteremia or sepsis. Blood culture should be drawn as soon as possible, ideally before antibiotics. They can identify the bacteria and allow for AST, which is especially helpful in the lumbar puncture is delayed if the lumbar puncture is delayed or can't be done. Second is the blood markers of the infection. Tests like peripheral white blood cell count WBC, C-reactive protein CRP, and procalcitonin PCT can help suggest if the infection is bacterial. High WBC, especially neutrophils, high CRP, and a high PCT are more common in bacterial infection. These guidelines give these tests a conditional recommendation suggesting they be considered where resources allow. Importantly, none of these blood tests can confirm or rule out meningitis on their own, and they should never delay performing a lumbar puncture if it is safe. They are supporting clues interpreted alongside clinical signs and CSF results. Both CRP and PCT seems similar useful for differentiating bacterial from the other meningitis types. Earlier, we mentioned the differing lumbar puncture if there are signs of high pressure inside the head. Then how do doctors decide? This often involves cranial imaging like CT or MRI scan of the brain. But do all patients with suspected meningitis need a CT scan before the lumbar puncture? The WHO guidelines say no. Imaging should not be performed routinely. Why? Because it can significantly delay the diagnosis and life-saving antibiotic treatment, especially if scanners are not readily available. However, imaging is recommended before lumbar puncture if certain red flag features are present, suggesting a higher risk of mass lesion or severe swelling that could make lumbar puncture dangerous. What are these red flag features? So first one is very low conscious level, that is GC score is below 10. Then focal neurological signs like weakness on one side. Then cranial nerve problems, papilloedema, swelling of the optic nerve seen on the eye examination. New onset of seizures in adults only. Common febrile seizures in children usually don't require imaging first. A severely immunocompromised state like post-organ transplant, if the imaging is readily available and any of these are present, a scan should be done first. If imaging is not readily available and these features are present, the lumbar puncture should be deferred until the risky feature resolve. Crucially, the guidelines strongly emphasize treatment should never be delayed while waiting for the imaging, or if the lumbar puncture is deferred, blood culture should be drawn and antibiotics should start immediately. Okay, we have covered diagnosis. Now let's move to the critical aspect of treatment. With bacterial meningitis, time is of essence. The first step is urgent care. Anyone suspected of having acute meningitis need to be immediately admitted or urgently transferred to healthcare facility equipped to manage them. This is not something to manage at home. Depending on the severity, care might be in general ward or intensive care unit. Getting intravenous access is critical for fluids and medications. Before reaching the facility, should antibiotics be given before the patient even reaches the hospital or appropriate clinic? The guidelines gives a conditional recommendation here. It might be beneficial if bacterial meningitis is strongly suspected and there's likely to be significant delay in getting the patient to proper care. If given, it should be parenteral, that is injectable, preferably intravenous, but intramuscular if intravenous is not possible, but this should never delay transfer. After reaching the facility, once the patient arrives at a suitable facility, the guidelines are clear. Empiric intravenous antibiotics should be given as early as possible. Many consider the first 60 minutes the golden hour. Ideally, the lumbar puncture and blood cultures are done before the first dose, but diagnosis should not delay treatment. If antibiotics were given before arrival, then lumbar puncture should still be done as soon as possible upon admission if it is safe. Which antibiotics should be started initially before the exact bacteria is known? This is called empiric treatment. The choice depends on the most likely bacteria based on the age, risk factors, and local antibiotic resistance pattern. First choice, the guidelines strongly recommend starting the intravenous ceftriaxone or cefotaxime. These are third generation cephalosporin, effective against the most common causes, that is Streptococcus pneumoniae, Neisseria meningitidis, Haemophilus influenzae, and GBS. That is group B Streptococcus, and they penetrate the CSF well. Ceftriaxone might be preferred sometimes due to the wider availability and less frequent dosing. Covering for Listeria. Listeria monocytogenes is resistant to cephalosporins. If the patient has a risk factors for Listeria, the guidelines strongly recommend adding ampicillin or amoxicillin to the initial ceftriaxone or cefotaxime. Risk factors include being over 60, pregnancy, receiving immunosuppressive therapy, organ transplant, cancer, advanced HIV, diabetes, end-stage kidney disease, liver cirrhosis, or alcohol use disorder. Third is the dealing with pneumococcal resistance. In areas where Streptococcus pneumoniae is different, is often resistant to penicillin or cephalosporin, the guideline conditionally recommend considering adding vancomycin to the initial regimen. Local health authorities should define what counts as high prevalence. Rifampicin might be an alternative to vancomycin in some settings, but its use needs caution in areas with high TB rates. So when first choice is not available, like if ceftriaxone or cefotaxime are not immediately available, this is a challenge in some resource limited settings. The guidelines conditionally recommend considering a combination of chloramphenicol plus benzyl penicillin, that is penicillin G, ampicillin or amoxicillin. This is a second line option due to rising resistance issues with these older drugs. It's vital to investigate any reported penicillin allergy thoroughly before choosing alternatives. Most non-severe penicillin allergies don't prevent the use of cephalosporins. How long should this empiric treatment continue if the specific bacteria is not identified? So first one, in the non-epidemic settings, like if the specific bacteria remains unknown, but the patient has clinically recovered, fever gone, vital signs normal, conscious normal, for at least 48 hours, the guidelines conditionally suggest considering stopping antibiotic after 7 days. If recovery is not clear by 7 days, treatment should continue and further tests like repeat lumbar puncture might be needed. Second is the during confirmed Neisseria meningitis epidemics, empiric treatment with ceftriaxone should be given for 5 days only. This is a strong recommendation. Third is for during the confirmed Streptococcus pneumonia epidemics, the guidelines conditionally suggest considering empiric ceftriaxone for 10 days. Remember, these are for empiric treatment. Once the specific bacteria is identified by culture or PCR and its antibiotic sensitivities are known, treatment should be adjusted using the most targeted effective antibiotic for the right duration. Often 5 to 7 days for meningococcus, 7 to 10 for Haemophilus influenza, 10 to 14 for pneumococcus, and 14 to 21 days for group B streptococcus, and 21 plus days for Listeria monocytogenes. What about preventing spread? For meningococcal disease, people who have been in close contact with the patient are at higher risk. Post-exposure prophylaxis, PEP. Giving antibiotics to prevent illness is recommended for these close contacts. So who are these close contacts? Generally people living in the same household or those directly exposed to the patient's saliva, like intimate partners or healthcare workers during the intubation. In the week before symptoms started and up to 24 hours after the patient started on effective antibiotics. The exact definition might vary based on the resources. What antibiotics should give in post-exposure prophylaxis? The guidelines strongly recommend a single dose of either injectable ceftriaxone or oral ciprofloxacin. The choice should depend on local resistance patterns, especially as ciprofloxacin resistance is increasing globally. Rifampicin is a conditional alternative if others cannot be used. Prophylaxis should be given as soon as possible, ideally within days. Waiting longer than 14 days is likely not helpful. For sporadic, that is isolated cases, prophylaxis is given to contacts of laboratory confirmed cases. During large-scale epidemics, it should be given to contacts of clinically suspected cases. During smaller outbreaks, it depends on the resources and lab capacity. Remember, vaccination is the primary way to control meningococcal disease. Beyond antibiotics, there are other treatments like adjunctive corticosteroids like dexamethasone are sometimes used. The idea is that much of the damage in the meningitis, especially hearing loss, comes from the body own inflammation fighting the infection. Steroid might be reduce this inflammation. The WHO guidelines have specific recommendation. If an lumbar puncture can be done, intravenous corticosteroids, that is dexamethasone preferred, should be started within the first dose of with the first dose of antibiotic. If the CSF result then come back not suggesting bacterial meningitis, the steroids should be stopped. This is strong recommendation, though based on the low certainty evidence overall. Evidence suggests steroid might reduce mortality, neurological problems, and hearing loss, particularly with Haemophilus influenza and possibly Streptococcus pneumoniae infection. If an lumbar puncture cannot be done, for example, due to safety concern or lack of resources, intravenous corticosteroids may be started with antibiotics if bacterial meningitis is strongly suspected and there are no reasons not to use steroid, like suspected cerebral malaria. This is a conditional recommendation due to very low certainty evidence. During confirmed Neisseria meningitis epidemic, steroids should not be routinely used. Evidence does not show a benefit here. During confirmed Streptococcus pneumoniae epidemics, intravenous corticosteroids should be started with the first antibiotic dose. Evidence suggests potential benefit in its specific scenario. Steroids, if used, should be given IV, ideally with the very first antibiotic dose as or very soon after, and continued for maximum of 4 days if bacterial meningitis is confirmed, and strongly suggest, especially if caused by pneumococcus or Haemophilus influenza B, dexamethasone is preferred, but hydrocortisone or methylprednisolone are alternatives. What about the supportive care? So, should fluid intake be restricted? This was thought to help with brain swelling, but the guideline conditionally recommend against routine fluid restriction. Dehydration can be harmful. Patient should receive normal maintenance fluid, preferably oral or via feeding tube if possible. Breastfeeding is ideal for infants. If intravenous fluids are needed, isotonic solution like Ringer lactate or normal saline should be used. Moderate restriction might be considered only if there are specific signs of or a condition called SIADH and the patient is not in the shock. Agent like glycerol were studied, but evidence shows no benefit and potential harm. So the guideline conditionally recommend against its routine use. Other osmotic agent like mannitol might be used as a temporary measure in emergency if brain herniation seems imminent. But often other interventions like ventilation are needed. Generally, measures like raising the head of the bed can also help. Seizures can be complication of meningitis. These are called acute symptomatic seizures. Anti-seizure medications are used to control them. A key question is how long continue ASM after the meningitis is treated. So the guidelines conditionally recommend that if seizure occur only during the acute illness but don't reoccur afterwards, then anti-seizures medicine should be continued for no longer than 3 months. Continuing longer unnecessarily expose the patient to side effects and cost. The choice of anti-seizure medicine depend on the various factors. Meningitis can leave behind lasting problem known as sequelae. These can include hearing loss, vision problems, difficulty moving, learning disabilities, behavioral changes, epilepsy, or even limb loss. Managing this is a crucial part of defeating the meningitis roadmap. Early detection is key. The guidelines strongly recommend that all patients, children and adults, be reviewed for sequelae by a healthcare provider before discharge and at the follow-up visit, ideally within 4 weeks of the discharge. This helps catch problems early, allowing for prompt referral to appropriate services like rehabilitation. Psychological support for both the patient and caregivers is also important. Rehabilitation is a vital for managing sequelae. The guidelines strongly recommend the rehabilitation should be provided as soon as possible for anyone with sequelae. This can help people regain function, adapt to limitation, and improve their quality of life. WHO has developed a package of interventions for rehabilitation, or PIR, which outline essential intervention for various conditions, including neurological problems and sensory issues relevant to meningitis survivors. Rehabilitation is just not for after discharge. It should start early and be integrated into the care. Hearing loss is one of the most common devastating sequel. The guidelines strongly recommend that formal audiological screening, that is hearing test, be conducted for all patients before discharge, or if not possible within 4 weeks after discharge. Why urgency? Early detection allow for prompt hearing rehabilitation. For those needing cochlear implants, delays can lead to changes in the inner ear, that is cochlear ossification, that make implantation difficult or less effective. If hearing loss is found, hearing rehabilitation, which might include hearing aids, cochlear implants, or sign language training, should be started as soon as possible. Even if the initial screening is normal, a repeat test later is advised, as hearing loss can sometimes develop later. So, to summarize the key message from the WHO guidelines, suspect meningitis early based on the symptoms, perform a lumbar puncture quickly if safe to get CSF clues, start empiric IV antibiotics immediately, tailoring based on likely pathogens and local resistance, adjust treatment once the specific bacteria is known, use corticosteroid judiciously, especially in the non-epidemic bacterial cases, particularly with pneumococcus and Haemophilus influenza B, manage complications like seizures and raised pressure appropriately, and crucially screen all the survivor for sequel, especially for hearing loss, and provide rehabilitation promptly. Defeating meningitis require action across all fronts: prevention, rapid diagnosis, effective treatment, and long-term support for survivors. Thank you for watching the video. If you have any question or doubt, you can ask in the comment section. I hope you enjoy the learning. If so, share and subscribe our channel. Thank you.